I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host, and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in. Hello, my loves, and welcome back to the Love and Science podcast. Today, we're going to talk about something that is near and dear to my heart, which is planned egg freezing and also embryo freezing. But mostly this topic is if you're thinking about fertility preservation, either in the setting of wanting a family or potentially wanting a family someday, but not being sure if now is the right time. Or maybe your ideal situation is to have a family with a partner and you haven't found that right person yet for you. Or perhaps you actually have a fertility threatening diagnosis, such as endometriosis or even cancer. And situations are a lot more rushed and we don't have the luxury of time. But those are also situations where I see a lot of patients for consults. And also, I think it's important to talk about the nuances. So I wanted to give a little historical perspective. I was actually a fellow when ASRM came out and said that egg freezing was no longer considered experimental, which was a huge advance in the field. And I mean, if you're sort of just coming up now and don't know this history, it may seem, kind of strange to be talking about it. But truly, when I was a fellow and we had somebody who was younger, had a new diagnosis of cancer, they didn't have a partner, we truly told them to find donor sperm and to create embryos and freeze those embryos because the egg freezing technology was really not as advanced as it is now. And there were IRBs and research protocols where people could freeze eggs as such, but we weren't able to do something called vitrification back then, which is a fast freeze. And because of that, because the eggs have such a high water content in them, ice crystal formation would form, right? And think about your ice cube block in your freezer, if you have one of those like I do. And what happens is as the liquid freezes, right, it expands and it thaws, and then you can have all sorts of cell damage. And so what I wanted to share is that we now are able to do vitrification, which is, like, again, huge advance in the field, where success rates for eggs that are thawed, meaning did the egg in integrity survive the thaw, are upwards of 90 to 95%. And so, that is really huge to say that if you do decide to freeze eggs instead of embryos, that the output of those eggs will be comparable, to the same eggs used in a fresh IVF cycle. It's a really big advance in the field. Okay. So we talked about how it's no longer experimental. I also think if we look at the 2023 ASRM document on, specifically planned oocyte cryopreservation, we have to also talk about the cost, the safety, and the limitations. So what are the costs? Now, depending on where you are geographically, this can vary widely. I've seen, egg freezing, sort of in the $5,000 range. I've seen egg freezing in the $20,000 range or even beyond. And so I think it really does depend on where you are geographically. Some insurances cover, part, but not all. Some insurance programs cover meds, but not the rest, or vice versa. And some people even do medical tourism, which I don't necessarily recommend, but it does exist to defray some of the costs of fertility preservation. So it's not inexpensive to think about. And, I think the caveat is we always say, okay, the younger, the better, right? Freeze your eggs when you're young so that you don't have to think about infertility later. And I mean, again, I've changed my counseling. I used to say this was an insurance policy. It certainly is not, because there are some people whose eggs don't thaw well, et cetera. But I think that if we're thinking about being, on your way to your dream career, maybe you are a med student, maybe you're a resident, maybe you're in law school, none of these times are ideal times to be having children. And a lot of us on the career pathway, right? It's like, okay, we're focused on career, not meeting a partner. And not that one has to have a partner, but I think, if we're sort of checking boxes, as I tried to do in retrospect, really thinking about the fact that most people, as they're on their way to their dream career, do not quite have the finances to be able to pay for this out of pocket. And so thinking about creative means to get these things covered are available for some, but not all. And so just understanding that we have a big access issue too when it comes to these processes. What is the safety? Now, the safety really is very comparable to a regular in vitro fertilization cycle. So it's the same exact process, except we don't fertilize the eggs at the end. We take a woman through 2 weeks of injectable medications, the same hormones that exist inside the body, just at more concentrated, more concentrated forms, such as FSH, LH. We also usually give an ovulation blocker, usually antagonist, to prevent premature ovulation, and then a trigger shot, and then the egg retrieval, which is done, transvaginally. There's a needle guide attached to a transvaginal probe, and then we look under direct visualization, insert the needle tip into the, whichever ovary we decide to start with. Usually I start with either the more vigorous ovary or the more accessible ovary. It just really depends on the situation. But at some point, retrieving both ovaries fully so that that fluid goes through the tubing, goes to the lab, and then they can pick out the mature eggs later that day and then freeze them as such. Some labs are freezing immature eggs right now. Mine is actually one of them where I work right now. But as of right now, we have not really proven in vitro maturation. And so that is why you might see a lot of labs actually discarding M1 or immature eggs, just because as of right now, they can't be fertilized by sperm. And so the research really has not advanced to the point where we could do that. However, I have hope, especially with ongoing research, that we will get to that place as well. And so if that's something that you're interested in, you can certainly ask your fertility lab about that. Okay, so safety. We talk about the very low chance of bleeding, less than 1%, the very low risk of infection. Many of us give antibiotics, ahead of time. I know the data are kind of conflicting on that, but, sort of perioperative antibiotics, usually cephalosporin, to try to reduce the risk of any infection, but that risk is very, very low. And then there's the very small risk of injury to structures. Again, we're doing this under direct visualization. So injuring the bowel, the, urinary structures, having an injury that would require additional procedures, exceedingly rare. But I always mention it in my counseling because, it is theoretically possible, sticking a needle from the outside to the inside. And I think, informed consent is really important. I think the emotional risk is something we don't talk about enough. So people always say, what are the side effects of IVF? And I can say, okay, well, you'll probably feel bloated. You might have some headaches and you might have some mood swings. But I think that, the neuro wiring that goes to and from our brains, really, that involves the fertility circuits, like childbearing for so many of us and the hope of having a child or a family someday is so deeply ingrained that I think that the fear centers light up, the threatened areas, especially if a cycle's not going very well. And so there's just so many data points and so many calls from the nurses and the portal messages and the blood work and the ultrasounds. And especially if this is not your wheelhouse, it can be really, really overwhelming to feel like one day things are going well and then the estrogen starts to stall. And then what does this mean? Am I not going to have a family? And these are very typical experiences that people have as they're undergoing the process. And so I always try to say to my patients and my clients, okay, have an action plan for the next 2 weeks because it's almost going to be too much information. And so, this does not necessarily correlate to having a family in the future. It's something that's a very proactive thing to do. So try and, have a good relationship with your REI, as we always talk about. Try not to go down the Google rabbit hole. I'm always happy to explain things to people. But I think the emotional risk of trying to preserve, fertility for the future, if it's not going the way that we want it to, or even if the expectations are different than reality, like say you have 18 follicles and they get 13 eggs, I would say that's pretty fantastic. But there's just that part of us that says well, what happened to the other 5? And didn't I make those follicles? And was the egg immature? Did the REI not get it? Did the egg disintegrate? There's something in our human nature that just is going to feel disappointed at the data in some way. And I think we just have to brace ourselves for that and have a plan. Okay, so the limitations, I think the newest document is pretty good about talking about the limitations. Like I said before, I used to say that this is an insurance policy for the future. I have now taken care of so many women who were very proactive. They froze their eggs on the earlier side. And then they went to go use them, and either the eggs didn't thaw well, or the embryo development wasn't good, or, and maybe they're like 42, 43 at this point, and it's harder to get, good eggs and good embryos. And so, I always caution people that like, this is a tool that we have in the toolkit, especially if you know that fertility is going to be delayed for various reasons. Maybe it's medical training. Maybe it's you and your spouse, have a long distance relationship and you're not going to be together till a certain point. Maybe, there is a fertility threatening diagnosis, like whatever that is. But what I would say is that the endpoint that we're actually looking for is having a baby. And so, many people would call this anti-feminist, but I don't think it is, because my goal is to help people have babies when they want them, and also not to have them when they don't want to have them. And so there's so much regret in people who have frozen their eggs and then later try to use them and it's not going well. I always say to people, if you think you're in a position where you might be able to welcome a child into your life right now, trying and seeing the results of that in this moment is always going to be better than, putting your hope 4 to 5 years down the road. And then, what you freeze is what you freeze. And it's just really hard to know how those things are going to turn out. We do have calculators. The Brigham Women's calculator is really good in terms of like looking at, okay, what's your age? How many mature eggs do you get? What are your probability of having 1 live birth, 2 live births, all those things. And there's all these different studies that we quote. I pull them up in the office and I'm seeing my patients, looking at your age, looking at how many children you want, and like how many eggs would you need to freeze, and there's curves. But I do think that we do have to understand that none of us has a crystal ball. There are significant limitations to these projections in the future as you're aging, as we're waiting for people to use these eggs and potentially embryos. And that, that can be really hard if it doesn't go well. It goes well most of the time, right? I have so many patients and clients who have conceived this way. I even froze my own eggs in my divorce. I'm happy to share more about that on a different time. But I think that there are limitations to egg freezing as such, and I would be remiss if I did not call those out. Okay, what are the success rates per age? I typically quote, I really like a study that says there's an 8% chance of live birth for a mature egg under the age of 35. And now that's another reason I say, if you think you're not going to be having children by 35 and you really want a family, that's a great time to freeze your eggs. Other people, cost benefit analyses say maybe more like 37, 38 is the sweet spot. But even cost benefit analyses have their limitations. And so, the under 35 demographic is really a good one when you're looking at egg freezing, because eggs are younger, that they have more energy, the mitochondria are better, and those eggs in the future are better able to shuttle the chromosomes where they need to go. And, I think the good news is that the eggs don't age with us, right? So say we freeze our eggs at 34 and then we decide to use them when we're 37, 38, like the uterus may be that age, but the eggs are the age of the eggs when they were frozen, which is, always really helpful. There's a whole range. We don't have a ton of data for 40 and beyond. If you look at the numbers, like under 35 is the best. And then, up to 37 is a little bit worse. And then, 38, 39, even worse. And then 40 and beyond, we don't have a ton of data. And it really, there's some studies that suggest that you'd need to get to like 50 eggs to get to 1 live birth at older ages, which, how many eggs can you get in a given cycle? Maybe if you get 20 eggs each cycle, that's a reasonable number to shoot for. But I think,
Hello, my loves. I am so excited to share this news with you. If you are a female physician navigating the fertility journey and you want a structured, evidence-based plan, I have created a free resource for you. It's called the Physician Fertility Roadmap. I have created a guide to help you optimize your chances of pregnancy and a successful outcome over the next 6 to 12 months. Check out the link in the show notes. Love you. Bye.
Just understanding we are very inefficient the older we get. Now, if somebody came to me and really wanted to freeze their eggs at older ages, I feel like everybody has a story. And so listening to their story, some clinics unfortunately do have policies about when they can freeze and can't freeze eggs. I do think really that we should be looking at the AMH as part of the equation. We need to be looking at the social situation. I think it's really important that we take every situation in context, but there are also some clinic limitations. And I want people to know that if you're thinking about freezing your eggs, there may not be an indefinite timeline on that. Earlier is definitely better. And there are some, sort of structural concerns to think about as you navigate the system. Um, let's see, what is the process? We talked about the process. I think that one part we did not yet talk about is what to do after you freeze your eggs. And so the eggs are frozen where you are, in the world, in the clinic. And then most offices will actually recommend offsite storage. If your clinic is not recommending offsite storage, please do compare the cost of storing at your own clinic versus, storing at an offsite place. I did store my eggs offsite just because I ran the cost comparison and it was so much more reasonable. I went to a reputable place. But again, I think that people spend hundreds of dollars a year, freezing their eggs or keeping them frozen. And those costs can really add up. Think about what we could be doing with that money otherwise. So, thinking about where that's going to be. And then if you decided to use those eggs, and I mean, last study I looked at said about 10% of women who did freeze their eggs returned to use them later, which is kind of an interesting number. Wish that was a little higher. Maybe we're making progress there. But, thinking about, okay, then I would have the egg shipped to either my original clinic and I would travel there, or I would have the egg shipped to where I lived at that point in time, as long as the lab, the freezing and thawing protocols were comparable. And so, thinking about those logistics, most places can accept eggs that were frozen in a different place. But again, it's all a physics equation. So making sure that those two things match is really important. Okay. So we talked about, the basics of egg freezing, sort of the history, the cost, the safety, the limitations, success rates, the process. I think the important thing to think about also is, like, I have some people come to me and they're unsure whether they want to freeze eggs or embryos, and they are also doing fertility preservation. So for instance, say I have a 33-year-old resident who's not going to be out of training until she's 38, she's married, she wants to, think about fertility preservation. That's somebody I actually might encourage to freeze embryos because you have more information about the embryos. It's not that the eggs do better, whether they're frozen, and frozen as eggs or brought to the embryo stage. It's more that so many things happen, right? An egg has to get fertilized. That fertilized egg needs to grow to the blastocyst stage. That blastocyst then has to implant. And so I think that if you are talking about the progression from a frozen egg to a day 5 blastocyst, we have a lot better data. Like, for instance, a blastocyst could have a 50, 60, 65% chance of success. And it basically, that there was a lot of attrition on the way there, which is why we say, really best case scenario, there's somebody that says 12% per mature egg frozen, but I still like the study that says 8%. So it might take like 10 mature eggs, right, to have an 80% chance of a live birth. That's just sort of how the numbers go. And that's because, are those, eggs going to make blastocysts, and how many? And each blastocyst doesn't necessarily yield a child. Those are all things to think about in the equation. So if you're in a committed relationship, it's stable, this is your person, and you can project out, it might be the difference between saying, okay, I, got 10 eggs retrieved and I have 5 blastocysts. I think that's a good number to have, versus, okay, I had 10 eggs retrieved and I only made 1 blastocyst or no blastocyst out of that group. I think I want to do another egg freezing cycle while I'm still young. And so I hope that makes sense. It's sort of helpful to say, like, what was the embryo progression if we're able to freeze those eggs in real time, and then people will have more information to know exactly what's frozen, do better calculations in terms of what the ultimate output would be from that cycle. And then also, importantly, the decision, it's not inexpensive to do another cycle. Also, time-wise, especially for those of us who are so busy, like, when are we going to do that? Like, that sort of risk calculation of, like, does this make sense in the context of my goals to go through this again? I do think sometimes if you have embryos frozen, it can be a little bit easier to make those decisions. But if you don't have that information and you want to be conservative and you want more eggs frozen, that's usually the right answer. But again, we just don't know how many embryos that's going to turn into and how those embryos are going to go once we start doing transfers. So considering embryo cryopreservation instead of egg cryopreservation when we have, or even donor sperm. I mean, I have some young women who really don't want to freeze eggs as eggs, and they want to, fertilize a donor sperm and see the output of those things. I think that's actually best in the older population because, if I can freeze eggs under the age of 35, I can feel pretty confident that those eggs are going to do well. Again, not 100% certain, but those eggs are likely to perform well. If I have somebody who's 39 and a half and she comes to see me and she wants to freeze her eggs, but she's single and she freezes even like 10, 15 eggs, it's really hard to know how those are going to pan out. And if she's waiting for a partner to use those eggs, if that's her situation, then I don't want her to finally meet somebody a few years later when she's 44, 45, right, for instance, and then not be able to get more eggs or embryos if that batch didn't go well. And so that's a situation where sometimes I actually use that data. Like if we're going to do more than one cycle, I might say, okay, let's do the first cycle where we fertilize with donor sperm, especially if you think you'd be willing to conceive either as a single person or, in a relationship, and say, hey, these are my embryos, let's use them. Usually I would say, okay, fertilize with donor sperm first. And then if that person did want to then do another cycle and freeze eggs as such, I would feel more comfortable doing that, understanding that that's a person who makes blastocysts if that's been the output of their cycle. But if they had eggs fertilized by donor sperm and that didn't go well, that's somebody, again, you never know, was it an egg problem or a sperm problem? Usually an egg problem. I would be a little bit more hesitant to have that person bank eggs without knowing the status. Again, patient autonomy, is very important. But I think knowing that sort of gives a window into the egg quality if we can have a little bit more data about the blastocyst progression. Again, this is all very nuanced, but I did want to address, when somebody might consider embryo fertility preservation over egg fertility preservation, and those sorts of scenarios. Now, as a divorced person, I am very, very direct in my counseling because I will say that even in my own divorce, I had to fight for my frozen eggs. And so I always want people to know that it is really important that if you want children in the future and you are at all ambivalent about your partner at all, the right answer is to freeze eggs as such, because as soon as those eggs are fertilized with whoever's sperm, they become the marital property, the property of the couple, and they are seen in the court, usually speaking, as sort of either both people are on the same page, and once that marriage dissolves, there's child support and all these different things that come into play, and most courts will not allow the use of those embryos. And so it is so heartbreaking. I work with people on a weekly basis who are being faced with potentially having to discard their embryos because of an unstable or dissolving relationship. And sometimes these women have been with the wrong person for a really long time, and their ovaries are on the older side. Sometimes it's really, really nearly impossible, if not impossible, to generate embryos with their own eggs at that point in time. And so this is why I say, if you are all ambivalent, some people who want to do this actually freeze half as eggs and half as embryos, which I don't think is a wrong choice. If the relationship dissolves, then you kind of have to part ways with that half that are fertilized eggs, but at least it's better than losing everything. But again, if there's any ambivalence whatsoever, like I said, I'm pretty direct in my counseling now. Freeze eggs as such. It leaves the most flexibility. It leaves the most chances of using those eggs in the future. And if there's any sort of relationship that dissolves, and again, you never know. My divorce was very unexpected, I will say. Again, let that not be my bias, but I feel like I've gone through something terrible. I see it all in my practice all the time. I see really sad situations regarding, sort of what do we do with this biological tissue that's been created? And if somebody had frozen eggs in the very beginning, I don't think that would be a problem. And so I just wanted to share that. Okay. So I wanted to say, what's a caveat here? One of the caveats is you don't necessarily have to do this, right? And like I said in the beginning, if fertility is something that's really important to you, and you know that all you've ever wanted in your life is to be a mom, and you think that there is a pathway forward in this moment in time, or maybe you've dabbled in IVF and it hasn't really gone very well, and you're starting to wonder, I mean, IVF is not fertility, right? Like, especially in people who have never tried to conceive before, who come to me for fertility preservation, say the cycle goes badly. I mean, it might make me worry about underlying egg quality at some level, but those are two very different things than somebody who's going to be infertile. And so, sometimes if somebody comes to me and they're like, I think I want to freeze eggs, we try to do 2 or 3 cycles, it's not going well, they really want a family, we might shift the conversation to talking about, thinking about donor sperm and maybe trying IUIs with donor sperm, or maybe, changing the pathway slightly, because IVF is not the be all and end all. Yes, it does allow for, fertility preservation in the future. But if what somebody really wants at the end of the day is to be a mom at some point, the best chance is going to be to try with the sort of younger age and then see if a pregnancy and a live birth are possible. I think it's really important to think about, okay, I'm here freezing my eggs for a reason. What would it look like if I were to build my village now, here and now, and see what happens? And it's always a hard conversation, but I do offer that because I think starting to just ask those questions, how can I, what resources do I have? Do I want to put this off any longer, or do I find a way? And I think single parent procreation is, becoming more and more common, and people are banding together. They're raising their children together. It really does take a village, but it doesn't mean that you have to wait to find a partner to be a mom if that's what you've always wanted, especially in the face of, information where IVF is not going well. Okay, my friends. So I hope this was informative. I adore talking about egg freezing. It blows my mind how the technology just keeps getting better. But I do think that there's also some caveats that we discussed that are really important to consider. So again, I hope this was helpful. You know how much I love you. Until the next time. Bye.